Good afternoon, and thank you for joining us for today's webinar presented by Cancer Commons in partnership with Travera. Our webinar today is Recurrent Cancer, Unique Treatment Guidance After Cancer Returns. We know that we have many of our clients and caregivers on the webinar today, but for those new to the organization, we'd like to provide a brief overview. Cancer Commons is a nonprofit network of patients, physicians, and scientists united by a shared goal to optimize each patient's outcome and maximize collective learning to the benefit of the next patient. Since our founding in 2011, we've delivered personalized, evidence-based guidance at no charge to more than 10,000 patients and caregivers, supported entirely by philanthropy. Cancer Commons is staffed by accomplished researchers with PhDs in the molecular biology and pharmacology of cancer and in artificial intelligence. They have joined the Commons to apply their knowledge and expertise to help patients research their options in real time using the latest tools of precision oncology. You can learn more about Cancer Commons and find information and support at our website, www.cancercommons.org. For today's webinar, all participants will be muted, but we encourage you to submit questions at any time during the presentation via the question and answer box. Today's presenter is Dennis Watson, Vice President of Business Development with Travera. Dennis has spent the last 15 years of his career working in genetic and genomic testing in cancer. He joined Travera last year and has spent that time focused on enhancing the testing process and building a key focus on patient advocacy, all while directly interacting with every physician and patient who moves through the Travera process. Like each one of us, Dennis's family has been closely touched by cancer, and this has inspired his passion for the work Travera is doing and his desire to keep the patient first in everything they are working to build. And now I'd like to introduce Dennis Watson. Thank you so much.
Thank you very much for the kind introduction, Shan. I appreciate everyone joining today and hope this will be informative for all of you. We're very excited about the work that Travera is doing, and we're going to take the next few minutes to share that with you. And as we go through the presentation, I'm going to cover sort of the challenges that we're trying to address with our technology and the solutions that we have been able to bring to the surface and the science that we've been able to advance, and what that process of testing might look like for you if it makes sense for you. We're also going to we are working, I should say, to build a late stage cancer database to help not only the individuals that participate in that database, but also future individuals. And we're going to go through the explanation of all this and the next steps, and then we'll take questions and answers at the end. We've done a previous presentation with Cancer Commons, and so for some of you, you may have seen some of this information before. Some of it will be new, but the technology is unchanged, and we're very excited about what it's able to do. So what I'd like to do is start by beginning to set up a little bit of the problem that exists in cancer care in not only the US, but globally. And if you're faced with late stage cancer, oftentimes you've been through multiple regimens, multiple drug options, multiple therapy options in different ways. But if you look at the current FDA approved drugs in the US, the FDA has more than 300 approved drugs for cancer treatment in the US today. And we have really nice guidance that our physicians follow and that you can identify and follow through as patients through the NCCN guidelines, ASCO guidelines, and others that provide excellent decision trees in guiding therapy decisions based on your unique cancer, your unique diagnosis, and it helps to identify which drugs should be used at which stage. The problem, however, is that while this approach is pretty effective for frontline and early stage disease, when you look across stages of all cancers and you look into late stage specifically, the success rate of those individual drugs or targeted inhibitors or immunotherapies begins to decrease at a fairly rapid rate. And across all stages, it's really a poor response rate in late stage disease. When we talk with patients and when we talk with oncologists, especially when we get honest feedback in those environments and those settings, the reality is the oncologists sort of will admit that in late stage we're guessing in some capacity, and patients just can't believe that that's the case. There's so much data out there in genomics and in genetics and in other areas that we just have to believe that there's a better option. And the reality, though, is that we're still not doing a great job in late stage disease. Cancer right now is still the #1 cause of death in the US for individuals under the age of 85 years old. And so what do we do? What can we do to help increase the likelihood of a clinical response when we move beyond that standard of care treatment option? When we get into the advanced stage setting and we've tried the frontline things and you're facing potentially a recurrent disease, what comes next? And I'm going to put up on the screen here an example from the guidelines. And this happens to be in recurrent ovarian cancer. But there are similar pages in the guidelines that look like this for just about any disease you might search. And what patients are often faced with is a list somewhat similar to this one, where there are 30 plus therapeutic options for recurrent disease. And you notice many of them in the cytotoxic chemotherapy column here, for example, they're listed alphabetically. There's not a great deal of guidance there. And so what we really need is a fast and reliable method to identify therapies for late stage patients that have greater than 20% response rates. And there have been a ton of innovations in precision oncology and genomics and immunotherapies, things like the checkpoint inhibitors, and lots of great progress and increasing promise in all of these areas. But we're still not addressing this unmet need as directly as many of us in the space of genetics and genomics had hoped to in the early days of those projects. And so while we're continuing to see advancement, there still is a great opportunity to do better. And so one way that we have looked to approach this is actually stealing from an area of another space in medicine, in the infectious disease world. If you have an unusual infection and you go and see an infectious disease specialist, they don't go to their version of the NCCN guidelines or the ASCO guidelines or even really the published literature on a specific cancer to a specific drug or a specific bacteria to a specific drug. What they do is they take a biopsy of that unusual infection and they culture it, and they grow those cells and then create more cells from that specimen. And then they test different antibiotics or different drugs against it. They might test 10 or 15 different drugs, and then they give the patient what worked, what killed these cells. It's a very logical approach. It makes a great deal of sense. And so the obvious question, sort of comes, why don't we just do this with cancer? Why don't we just take out some live cancer cells, figure out what drugs work against them, and give those to the patient, give those to me? And the answer to the question is that we actually have tried this in cancer. In fact, we've tried it for more than 70 years. This approach has been around since the 1950s. And we've tried it through live cell cultures, through mouse models that they sometimes call PDX, more recently with things called organoids. And there's a fundamental problem, however, that exists in all of these approaches in our belief. And that is that growing cancer cells creates an issue. And the reality of cancer cells, or really any cell, once it's removed from the body and removed from its sort of life source, is that those cells will die naturally just because they're not being fed and they don't have sources of oxygen, et cetera. Those cells are going to die naturally within about 3 days. The average cancer drug, however, can take a week or more to work. And so we're left with this conundrum of time. how do we take out a live cell and test a drug against it if the drugs take longer to work than the cells die by themselves? And the answer is that we have to intervene. And that's what all of these approaches have taken over the last 70 years or so, since the 50s, is that we've intervened. We've tried growing cultures in petri dishes from that live cancer specimen. We've tried the mouse models and the organoids and all of these different approaches. And while we've improved in that approach, and the organoid approach allows us to maintain more of the microenvironment of that tumor because it grows those tumors in a three-dimensional environment, the reality is that cancer cells just don't like to be grown and cultured the same way the bacteria does. When you intervene with a cancer cell to that extent, a cancer cell is a mutant by definition. These are mutated cells. And when we intervene, the biology inevitably changes. And there's lots of publications out there to show that when we do this, we see a shift in the cells. They don't always change, but sometimes they do. Often they do. And as the patient or as the provider, it's difficult to know whether what we're testing drug against here really equals what we took out of you or the patient here. And so Travera has taken a little bit of a unique approach in this area of science. Rather than figuring out how to keep the cells alive long enough to watch the drug work, we have actually figured out how to watch the drug work so fast that we don't have to intervene in the cells, making this the first drug test outside of the body, or ex vivo drug test, that can actually measure the patient's response to individual drugs against individual cells that are your direct cells, the patient's direct cells, and not some grown later iteration of those cells. And that's what makes our technology so unique and so novel in this area of ex vivo drug testing. So let me explain to you briefly how this works and what exactly it means. It's actually all made possible by the MIT Manalis lab, and this is a biophysics lab at MIT in Boston. And what they have actually developed there is this tiny little chip you see here on this fingertip. And this is an artist rendition of this chip, sort of blown up so it's easier to see. And these little blue lines represent fluid channels. And so we pass individual cells, live cancer cells, through these channels very rapidly. And they pass over this little thing here that looks like a diving board. And it essentially is. And as the cells pass over that diving board, the diving board vibrates, or the frequency of the diving board changes. Just like when you jump off of a diving board into a pool and the vibration of the diving board happens after you jump off, the weight of the person jumping off the diving board is directly related to how fast or slow that vibration is. And it turns out that this is an incredibly accurate measurement tool. And so we can measure the frequency that changes as individual cells pass over this diving board. Now, not to get too deep into the physics with you, but what we're actually able to do is recognize the change in mass of an individual cell that would be equivalent to that cell changing its diameter, or it's the length across the cell, by about 5 nanometers. Now, I know that's a measurement that most people aren't familiar with, but if you had a high school physics class, you might remember that the wavelength of visible light is between 400 and 700 nanometers. The reason that particular comparison is important is because the next best technology available today to weigh an individual cell is to use a light microscope. But light can't be more specific than 400 nanometers of diameter, because that's how wide a light beam is. We're able to measure these cells at a rate of about 5 nanometers of change. And so this is 100 times more accurate than the next best technology that's available. So what the team at MIT did was they took this to the team at Dana-Farber in the cancer research department there, and they said, we know that on average, a cancer drug takes about a week to kill a cell when the drug is working. We also know that when a cell dies, it loses about half of its weight. So the question was, with this highly accurate measurement tool, might a cell, in response to a drug that's working, begin to change its weight by a little bit in the first day? And the answer to that question was a resounding yes. And so we've been able to validate this now over 39 different cancer types and over 104 different FDA cleared drugs. And we're continuing to add to that every day. Now, as a patient who might be interested in this kind of a test, this is how it actually works. We start with live cancer cells, and I'll explain in a minute how we get access to those cells. But we would start with a specimen of live cancer cells that's sent to us in a special kit, overnight delivery. And in this example, I'm going to show you what it looks like to run one drug. We would put 5,000 cancer cells into this blue cup and 5,000 cancer cells into the gray cup. And then we just let that sit, let it incubate for 24 hours. And then we go back and we weigh the cells in each cup. We then look at all 5,000 measurements of the 5,000 cells in this cup, and we build this little graph that sort of shows the distribution or the average weight of the cells in that drugged specimen. And we then compare that to the average weight of the drugs in the control specimen. If the weights of the two cells, the average weights of the two cells, or the two 5,000 cell cups, is equivalent, then that basically tells us the drug hasn't done anything. This drug was a placebo. It's just really done nothing to change these cells. But if we begin to see the weight distribution in those two cups change to a significant amount, that's what tells us that this drug is beginning to work. And the way that we actually do this from a single small live cancer cell specimen is we run a 20 drug test at a time. So we will run as many drugs as we're able to based on the volume of cancer cells we get from the sample. And we will run up to 20 different drugs. And so if you are a patient who is in a position that you're looking to switch to a new therapy, you've already been 2 or 3 lines of therapy already. You look at that NCCN guideline page, like I showed earlier, or those ASCO guidelines, or wherever you look, and you see a long list of potential drug options of what might be next for me. The idea here is that you provide a small sample. We run 20 of those drugs in this assay. And then about 2 days later, we return a report to your physician that says, of these 20 drugs, these are the ones the patient's cells were sensitive to. These are the ones the patient's cells were not sensitive to. And then maybe there's a few that are sitting somewhere in the middle of that paradigm. And it allows your physician to make a more informed decision, utilizing drugs that are in most cases already indicated for your disease, but hopefully targeting better what may or may not work well for you. So this is all really cool and interesting in a lab, but the question often is, how does this translate to patient outcomes? And this is part of the reason that we're partnering with Cancer Commons. It's because we have excellent data in that environment, but the data is early and we're still learning. And so at this point in time, we have tested a few hundred patients, but we have full outcomes on about 55 today. And of the 55 patients, we've gotten 46 of them right. This means these are patients that received this test, had 20 drugs analyzed, ended up getting one of the drugs that were analyzed in the assay. And then some months later, we got their clinical outcomes. Was there a clinical response to this drug? Did metastases disappear? If a patient has a malignant fluid, ascites or a pleural effusion in the chest, did that fluid dissipate? Things like that were looked at as clinical indicators of response. And what you see on the screen here at 84% in the bottom right-hand corner is the current predictive accuracy of the test. So think back to that earlier slide I showed where in late stage disease, the average response rate of a drug in advanced disease across all tumor types in the guidelines is about a 20% likelihood of response. Here we're showing an 84% likelihood of a response. And it's really important here to note that this is a strong predictor of clinical outcome in both positive and negative predictions. And so to explain briefly what that means, this 85% number for positive predictions, that means these are patients that received a drug we said was going to work, and the drug did in fact create a response in that patient. The negative prediction, because these came out of clinical trials, are patients that received a drug that our assay said was not going to be effective. These patients ended up getting that drug anyway for one reason or another. And 81% of the time, they continued to progress. Their disease continued to progress through that drug. And so we're able to call on both sides of the coin. Yes, this is a drug you're going to respond to, and 85% of the time we've been right in that call. Or no, this is a drug you will not respond to, and 81% of the time so far we've been right in that call. As I said earlier, this applies right now to 39 different cancers and over 100 FDA cleared cancer therapeutics. We do have a really key focus as an organization on ovarian, pancreatic, lung, and colon cancers. That said, there are 39 other tumor types that we can and will continue to test, with a few exceptions that I'll outline in just a moment. But the main purpose of this partnership with Cancer Commons is to help both Cancer Commons and Travera and the community at large in serving to develop an advanced cancer database. We're looking to continue to develop not only our clinical trial information, but our real world clinical evidence. And programs like this give us an opportunity to do that, while you as patients get an opportunity to get access to a test that can give you insight to what you might do with your next therapy decision. We're partnering with Cancer Commons to provide free access to this testing at this time. The test, as you can see from the data, is new, and the data is very positive, but very young. So as I said earlier, we're still learning through this process together. Not every case is going to go perfectly. Sometimes we won't be able to get enough cells. But when we do get cells, and when we do see a clinical response in our hands, we feel very confident that the vast majority of the time that is also going to elicit a clinical response in the patient. And so working with Cancer Commons, we're able to give the patients that are connected to them and through them an opportunity to get access to this program. And this is also available through a clinical trial. And some patients and providers feel more comfortable doing this through an organized clinical trial. And so you see a link here at 𝗥𝗲𝗰𝗂𝗏/advanced-carcinoma. And this is a decentralized IRB approved clinical trial that is observational in nature. And so as a patient, you can actually go to that website, and there's more information about the trial. You can enroll yourself in the trial. Your treating physician does not have to be an investigative site or an individual investigator for you to be able to participate in this trial. It's decentralized, meaning that you can enroll in this trial from anywhere in the country, and the clinical team at 𝗥𝗲𝗄𝗏 will work with you and your clinician to get the result, to get both the sample and the results through us to you, so that your doctor can make appropriate decisions. And then 𝗥𝗲𝗄𝗏 will work to continue to collect follow-up data and how that goes for you. Our only real ask in return for offering this test for free right now through Cancer Commons is that you let us know what happened. There's a value to our organization of understanding real world evidence application of our tests. And so if you have our test done, we just want to know, did you end up going on one of the drugs that we tested? And if so, what happened? And we're actually doing that right now through a really simple HIPAA compliant survey. Some months after you get the test done, we would just send a link to this survey to your email or someone we've been certified to give that link to, a family member, whomever. And you can answer a few simple questions about what drug you ended up going on, whether or not a response was seen. And then sometimes that elicits additional questions from us. But it's a very simple process, and it just allows us to collect some experience and some information about the experience that you had. So who qualifies for this? And there's a couple of questions for that, and I'm sure we're going to take questions at the end. But ideally, this is for someone who's planning to bridge to a new therapy in the coming months. We are able to run the assay on patients who are currently in treatment with chemotherapy or other systemic drugs. We have learned that it doesn't work well if you're undergoing current radiation. But if you're undergoing current drug therapy, it is possible to send us those specimens. However, be warned that if the therapy you're on is working, we might end up getting a sample in the mail that has already died because those cells have already responded to those drugs, which could be, a good sign, but it means that we won't be able to run the test if we don't have access to live cells. So the ideal position for this is when you're looking to bridge to a new therapy or to switch your therapy, what you're on or what you've previously been on isn't working. You've recently had a recurrence, whatever the scenario might be that you're looking to initiate a new therapy, that is the point in which it makes the most sense to get this test because, like I spoke to earlier, cancer mutates and it changes in response to drug, it changes in response to different therapies. And so ideally, because we're testing real-time response of real drugs against your real cells, you ideally want to capture those cells in as current of a state as possible to make sure that the information you're getting is as relevant as it can be. And so if you were to get this test done today and aren't planning on changing therapies for 6 months, the reality is that the cancer might change in that period of time. And so ideally, you would want to try to do the test as close to the initiation of new therapy as possible. The second qualification is that we have to be able to access live cells. We can do this from a few different approaches. We can do it from a pleural effusion. If you have fluid in your chest or ascites in your abdomen, and you, especially if you're having those fluids drained at a regular interval, whether that's through a Pleurex catheter that you're doing at home, daily, or if it's something that comes up, on a monthly basis or bi-weekly when you just start to get uncomfortable from the presence of that fluid, we can work with you or your care provider to just get a small sample of that fluid, about 150 milliliters. And from that, we can extract out the cancer cells and we can run our assay from that fluid. The other option is from a solid tissue sample, from a fine needle aspiration, from a core needle biopsy, or if you're planning a surgery to debulk disease or anything along those lines, we can take a piece of that surgical or excisional biopsy specimen as well. Archive specimens like paraffin-embedded tissue or frozen tissue, et cetera, don't apply to our technology at this time. As I said, we're looking for chemotherapy or targeted therapy response against living cancer cells as they were existing in your body. And so getting cells that are old, that have been preserved in different ways means that those cells are no longer really alive and viable. And so we really do need to get your cells into our lab within about a 24-hour period after they've been removed. Right now, this applies, as I said, to 39 different cancer types. It works for essentially the leukemias and virtually all carcinomas, multiple myeloma. We cannot today do the test for the lymphomas, sarcomas, glioblastomas, or pediatric cancers. The pediatric cancer specifically is an area we will continue to look at and hope to offer in the near future. Some of these others just create challenges in access to the cells. And finally, the assay does need to be ordered by your treating clinician. This is a CLIA approved test, which means it does require an order. And so we will work very directly with you to help you through that process, to communicate with and educate your physician, as this is a very new technology that is undergoing both clinical trials as well as this real world access opportunity. Many of your physicians may be unfamiliar with our test. And furthermore, they may even have a little bit of a tendency to have a hesitation to ex vivo drug tests because of the history that I outlined earlier in the presentation. There's a lot of other tests that have been tried, but what again is unique about Travera's approach is that we're testing drug sensitivity against your cells. We're not growing cells to get there. And that makes this a very novel solution to a decades old problem. So in summary, the way that this works again is you would get connected to Travera, to myself. We would work with your physician to get the order. We would work with your physician to get live cells collected, either through a tissue biopsy or a fluid collection from the ascites or pleural effusion. The sample gets placed into our cold shipping kits that we make available and we'll send ahead of the procedure. And that's then delivered overnight through FedEx. We'll then analyze up to 20 therapies and 4 immunotherapies against your actual cancer cells. And approximately 48 hours after that, we'll deliver a report to your physician assessing the predictive likelihood of response to the drugs tested. You can see in this very small image over here in the right corner, the way the report comes out, it sort of ranks the 20 drugs and their level of sensitivity and scores them from 0 to 100, 0 having no sensitivity and 100 having a high sensitivity. And so it's a very simple to read report. And then you and your physician can use this to help choose your next therapy based on how your cells might respond to each drug. And then again, at some future point, we would request that you provide feedback to us on your experience and what happened in the application of our assay. So as far as next steps go, Travera and Cancer Commons are here to help. All you need to do is notify us of your interest. And seeking more information is no commitment to test. I'm happy to answer questions, both here at the end of the webinar, as well as via email. And you can just go to travera.com/contact, and there's a contact us link there where you can post questions or just post that you're interested in learning more about the test and proceeding. Or you can contact me directly. And I'm going to put my email address up on the screen here in just a moment. But once I receive your information, I will contact you directly. I'll answer any questions you may have, outline the clinical process and the next steps, and then work with you to communicate with your clinician to get them involved and your clinical care team involved. We'll also involve the clinical trial team through the 𝗥𝗲𝗰𝗂𝗏 trial that I noted earlier, if that makes sense for you and is appropriate. And then once you have the information you need, you can contact your care provider to share about our test and what next steps might look like. And that concludes the presentation. I'm sure there are probably lots of questions. I see a lot of things popping up in the chat. So I'm going to click on the Q&A here, and we'll just go through these questions in the order that they've been received. So first question from Tony: as a member of the mucosal melanoma community, we're seeing a low response to current drug therapies. Can you test rare cancers that have very little data currently available? Absolutely, we can. And I noted earlier that we have 39 cancers that are listed in our panel that we are validated in. We can test virtually any carcinoma with few exceptions. And so even if it's not listed in that list of 39, if it is a rare disease that falls outside of that list, please still don't hesitate to reach out, and we're happy to try to work with you through that. The 39 cancers that we have listed on our website really are cancers that we have predetermined drug panels for. So some of the rare diseases, we might have to work with you and your clinician to decide what drugs need to be analyzed. But that is absolutely something that we're able to do. So the next question from Blanche: how large does a tumor need to be to biopsy it for cells? So we don't actually need much. The tumor tissue that we get can be very limited, depending on the tumor type, and depending on the location of the mass, etc. There are inconsistent rates of success, and I'll speak to that, what I mean by that, a little bit more in just a second. But a single core biopsy, I've seen produce as many as 2 million cells. So it doesn't take much for us to get what we need. If you only have microscopic disease, there's probably not enough there for us to be able to test. You really need at least one core biopsy from a mass, from a metastatic lesion, a liver met, a lymph node, primary tissue, primary disease. The source is less relevant, as long as there are cancer cells in that specimen. One thing that we have learned, for example, and is, just in full transparency, is that breast cancer, while we've had some great success, tends to be a challenging tumor type. Breast cancer specimens can be sticky, for lack of a better description. And so it's hard sometimes to dissociate the cancer cells from the other cells in that specimen. And so we are perfectly willing to try breast cancer specimens, but it's something that isn't as consistently successful as ovarian cancer, for example. And so it's something that we're continuing to work through to try to enhance. But if you're a patient with a late stage breast cancer and you reach out to me, I'll provide you a little more detail about what our likelihood of success in being able to get cells from a biopsy specimen are, just because it's important to us that we're very transparent in what we're continuing to learn as we move through this process. So I don't want to say that it doesn't work with breast cancer, because we've had some beautiful successes, but we've also certainly had some patients that have gone through the process and we've just not been able to extract enough cells to run any drugs, and that's always a little challenging. So I like for people to know what to expect up front. And let's see here, just going through the questions. Julia, how are the drugs tested chosen? So we have developed our panels from a list of 104 drugs that we have currently validated in our platform. And we have chosen our panels based on the NCCN indicated drugs for that disease. We actually order the drugs starting with targeted inhibitors, moving on to cytotoxic chemotherapies. And if there aren't 20 drugs in the list indicated for a particular tumor type, we will fill out the bottom of the list. Let's say there are 15 drugs indicated that we've been able to validate on our platform. And so the last 5 drugs in the panel might be off-label drugs that are wide spectrum targeted inhibitors that may just provide some interesting insight to you and your physician to discuss. But for the vast majority, for the most part, we are running drugs that are FDA cleared and indicated for the disease you're fighting. As you know, we spoke to this earlier question about the difficulty of rare disease and limited treatment options. In cases like that, we sometimes have to be more creative, and we work closely with the physician and the patient to figure that out. So why can't we access sarcomas, glioblastomas, and pediatrics, from Phil? So the challenge with sarcomas and glioblastomas is really specifically about it's about the ability of pulling the live cancer cells out of the specimen. Sarcomas, because of the relationship to bone, are very difficult to dissociate the cancer cells from the other cells in the specimen. And so the result is often that the dissociation process damages or kills the cells. And so it's something we will continue to work on in the future. But right now we've had to just take off our list of indicated diseases. Glioblastomas, the access to live cancer cells in enough abundance from a brain mass is very challenging. And so that's the reason we're not doing glioblastomas at this time. And the pediatric cancers is simply just because we've only recently received our validation in the leukemias and in the blood cancers, and we've just added that to our indicated use category. Many of the pediatric cancers are leukemias, and so we will begin working towards the pediatric cancers in the near future, but it's just not the space that we started in. FNA gives very few cells. How many drugs can be tested on an FNA sample? Interestingly enough, we have had some great success with FNAs. Because now it does require usually multiple pulls, 3 or 4 pulls of the needle is what we request. But because the fine needle aspiration almost creates a sort of an independent single cell suspension just by its nature, we tend to lose fewer cells in the dissociation process compared to a core biopsy, where we have to separate the cancer cells out from the stroma and the other cells that might exist there. So we have had surprisingly good success with FNAs, and often we've been able to run the full 20 drug panel on those. Can the test be used in lymphoma that produces solid tumors? Unfortunately not. And it's, again, because of the dissociation process with the way those cells are attached to the other cells in the specimens. It's just outside of our indications today. Sorry, I'm just reading this question. I'm currently on alectinib for ALK-positive lung cancer in stage 4B. It's working well, but it can stop working at any time. This is good to have. I'll reach out when that stops working. That's great. Thanks, James. Good to hear that it is currently working for you. Prostate cancer to Brad is currently covered in our assay, and we do take solid tissue. So I recognize that getting solid tissue in prostate cancer can be a challenge. And so that's something that we are continuing to, we're continuing to work through. We haven't done a lot of prostate for that very reason. There just haven't been a great deal of samples that have been made available to us. And Kamudi, it says here that you would love to speak to this question live. I'm just now noticing that note. Would you like to come off mute and say something there?
Sorry about that. I believe she was hoping you would respond to that live.
Oh, got it. Okay, cool. Let's see. How do you decide which drugs to test the sample against? I think I spoke to that already. We could theoretically do more than 20 drugs. As I said, we run the panels based on the number of cells we get. We could theoretically do more than 20 drugs, and we have done that in the past. For example, we've gotten 2 specimens from patients that actually have 2 different diagnoses, and we'll try to run as many drugs from both panels on each specimen to see if there's any crosstalk. So we have done that in the past, but in the majority of cases, 20 tends to be about the higher end of what we're able to do. How long do we expect this to be available? So right now, we expect to keep this opportunity for testing at no cost through Cancer Commons available probably through at least the end of this year. There's a possibility that might even be extended further. But as I said earlier, there's a mutual benefit in it. As a patient, there's an opportunity for you to get access to a very novel cutting edge technology. And it also affords my company and organization and the opportunity to learn from those experiences and continue to build out our real world evidence experience that sometimes is different than what you see in direct clinical trials. So another question about how do we select which drugs, and so again, and I think I spoke to this earlier, but I will add one caveat. We do have the panel of 20 drugs that is standard. So for example, if you have pancreatic cancer, we have a predetermined list of 20 drugs for pancreatic. Because we don't always get enough drugs to run every single specimen, we will run as many as we can. We run them in order from 1 to 20. And so if the first 3 drugs in that list are drugs that you've recently been on and progressed on, and it makes sense to say, hey, skip these drugs, I've just tried them and they didn't work for me, we can make those adjustments. Can we test the combination of drugs? Can we test a combination of drugs and test drugs that are not yet approved by the FDA? We do some drugs in combination, and that is certainly an opportunity that we can continue to expand and work in. But most of our drugs are done as monotherapies. As far as drugs that are not yet FDA approved or investigational drugs, that's not something that we have delved into yet. We're a young team with limited bandwidth. And so what we're trying to do is validate all of the FDA cleared drugs first. And so as we work through those and we get the FDA approved drugs that are indicated for the cancers that we're currently targeted to and available for, which continues to be a much larger list than we already have, the next step would be adding investigational drugs. So there's a question here about whether or not we expect sarcomas to be added at some point in the future. It's not something that we have on our short-term radar. I don't want to say no, but the dissociation process of those cells in sarcoma has really been a unique challenge for us. And so it's not something that we're deeply focused on trying to figure out right now. So this is a question about, as far as the collection and shipment, when patients, when maybe the ordering oncologist and the surgeon performing the surgery are at different institutions, I can work through that entire process with you and help to coordinate all of those moving parts, communicating with those physicians, et cetera. We have plenty of experience doing that, and we're happy to help through that. I think most of these other questions so far I have addressed in one way or another. Could we use this test in the context of high-grade appendix cancer? Absolutely. In fact, we did it in appendiceal cancer just about 2 weeks ago. That elicited a really interesting result. In fact, we did that in partnership with a HIPEC surgeon looking to use some different drug options in a HIPEC approach. Appendiceal goblet, I don't know that we have done that, but I suspect we could. If you want to email me at the address here on the screen, I'm happy to get some more information on that. Here's a question about someone with a pending biopsy and reaching out. If you are interested in having this test done and you have a biopsy that is coming up or a fluid drain that is coming up, it's always best to try to take advantage of those opportunities when they exist. Because our assay is not currently reimbursed, and we're continuing to build data in partnerships with Cancer Commons like this, The procedures related to collecting for our specimens are also not reimbursed if this is the reason they're doing the biopsy. And so I always recommend to patients really having us piggyback off of a procedure that is already scheduled, or even working with your doctor to have a procedure scheduled for another clinical indication. If the physician orders the biopsy purely for the reason of doing a test that isn't approved or covered by the insurance company, it's likely that they won't cover the biopsy either. But if they're already doing a biopsy, it's an easy thing for that interventional radiologist or surgeon to just take an extra quart or two and send those to us while they're taking the specimens they need for the other indication of that biopsy. So if you do have a pending procedure, and you're on a little bit of a timeline to that, we're happy to work with you and help to meet that as rapidly as possible. Could we test a drug that's in a clinical trial? Not at this time, but it is something that we should be able to do more of in the near future. So the cost outside of this partnership right now, we're making this assay available as often as possible to patients at no cost. And so we're always happy to talk with anyone through that, through that experience and through that process. But the list price of the test is $3,500. But as I said, if a patient is willing to work through this with us, we're happy to waive that fee and figure this out and do it in terms that make sense for them. And I think that is the majority of the questions. I think the rest of the things on here I have pretty much addressed. Can a usable biopsy be taken from infiltrative pMMR colon cancer? Probably. It would depend on the size of any tissue that's available. So again, if you would like to email me directly, I'm happy to try to figure that out with you one-on-one. And then there is some things in the chat. I don't know if any of this is different. This might be some of the things that community pulled out. So let me just take a glance at these. So there's a question here that says, my mother's oncologist is at Memorial Sloan Kettering and says that this analysis would be interesting, but would not drive her clinical thinking. This is not wildly uncommon. This is, as I tried to be clear in the earlier parts of the presentation, this data is young. It is very encouraging, and the early data we have is very, very positive. But it's not uncommon that you run into an oncologist who is skeptical, especially given the 70 years of prior history that exists with ex vivo drug testing. But the approach that Travera is taking is uniquely different than any of those previous generation ex vivo drug tests. And I'm often surprised in one-on-one conversations at how open many oncologists are to looking at and considering the results that our assay produces. Because often in most cases, it's not recommending drugs that are wildly different than what the doctor is already considering. Because we're running drugs that are in most cases clinically indicated for this disease, the doctor might already have 2 or 3 drugs in mind and is sort of trying to make an intellectual decision based on a lot of different factors about which of these 3 or 4 drugs they'd like to try on you next. And then they get this report back, and it happens to show that 2 of the drugs they've got in mind are sensitive, and 2 of the drugs they have in mind aren't sensitive. And it turns out that can be a little more informative and guiding for that physician than they give it initial credit for, because we're not telling them they need to do some crazy off-label indication. We're just saying, hey, here's 5 drugs or 4 drugs that you were already thinking about. it turns out that in our hands, some of them are sensitive and some of them aren't. So you already had these in mind. Let's be a little more targeted in what we try next. And you know, and as we work with you as a patient to communicate with and work with your doctor, that usually goes well. I have personally interacted with and dealt with a little more than 200 cancer patients over the last 6 months or so in this test. And among that population, I've only had about 4 times when either the oncologist or the interventional radiologist that was intended to collect the specimen has just simply said, I'm not going to do this. The vast majority of the time, when you as the patient go to your physician and you're informed about this and you say, hey, I understand what this is, I understand what it isn't, but what if it opened up a new opportunity for us or just gave us more guidance on what we were already planning to do? Why not? Most oncologists at this phase of care are open to trying this out with their patients. And I think the rest of the questions that are listed here from Community and my chat, we have already addressed.
Dennis, thank you so much for a wonderful presentation. We send our thanks to Travera, and we also want to thank everyone who attended and submitted a question today. We will be sharing the recording of this presentation with everyone who registered, and we will post it to Cancer Commons website, our YouTube channel, and all of our social media. Please feel free to send any additional questions you have about Cancer Commons webinars to education@cancercommons.org. And finally, if you or a loved one need assistance managing advanced cancer, Cancer Commons is here to help. Please contact us at any time via our website, cancercommons.org. Thank you so much, Dennis.
Thank you, Shane. Have a good day.